This lecture is part one of Schizophrenia Spectrum and Other Psychotic Disorders. Schizophrenia is one of the oldest mental illnesses ever recorded. Of course, many years ago, it was people with schizophrenia were thought to have demons in them or some other kind of spiritual problem. But the first person who coined the term schizophrenia was Beuler in the late 1800s, and it comes from the Greek, which means schizo, split, and phrenia, mind. So it literally means split mind. So what we're talking about here are people that have a gap between the internal and the external realities of their lives. Beuler looked at the 4 A's: association, affect, autism, which then meant social interactions, communication, that sort of thing, and then ambivalence. So let's kind of talk about these a little bit. As I'm talking with you on this lecture, I have hopefully some good associations. So I am talking to you about schizophrenia. So we're going to talk about things like positive symptoms, negative symptoms, hallucinations. These are all things that go with schizophrenia. If I started talking about black cup or a blue iPhone, that would not go with schizophrenia, really. I mean, maybe tangentially it would, but it wouldn't really. So association, I'm associating things together. People with schizophrenia have sometimes loose associations where they are talking about things that don't particularly line up. Their affect can be troubled. Of course, they can hallucinate and have other problems. Often they are very isolated and loners because communication and social interactions are very hard for them. And then there's also kind of this positive and negative values that exist at the same time. Again, we'll talk about positive and negative symptoms in people with schizophrenia. We'll get into that just a little bit later. There's a lifetime prevalence of about 3.2 million people in the United States who have schizophrenia, but only about 0.5% of them are treated in any given year. So costs the United States well over $30 billion a year to directly treat people with schizophrenia. And so this is a really serious health problem in our country. The most serious problem is that 1 in 10 people die by suicide who have schizophrenia. It's found all over the world, but it's a little more common with people born in urban areas, industrialized nations. So when we look at this phenomenon, it's weaker in cities that have 1,000 to 500,000 people, and it's nearly absent in cities with less than 10,000 people. That's thought to be related to social stressors. I mean, just think about living in somewhere like Chicago. If you are having delusions, hallucinations, think about how difficult that would be, just the density of that population and the press of all the people. It's estimated that schizophrenia costs more than all cancers combined. And, a lot of people think that people with schizophrenia can't work. I'll never forget one time I worked at a hospital in Lexington in a psychiatric unit, and we treated a physician who had paranoid schizophrenia, and it was the most amazing thing that I'd ever seen. He got through medical school, he practiced as a physician, but he had a diagnosis of paranoid schizophrenia, and when he became sick, he would come into the hospital. He knew enough, to come into the hospital. They would mess with his medicines a little bit, and he would be okay. So we talked about homelessness earlier, how so many people are homeless because of schizophrenia. Again, it's very hard to live on your own with profound a profound diagnosis of schizophrenia. These folks occupy about half of all psychiatric beds. So we're looking at first break. For about 90% is between age 15 and 55, and I know that's a really large spectrum there. But what we're really looking at are the early 20s, early to mid 20s. That's a good kind of, if you sort of think about this as a bell curve, and in the middle of that bell curve are I'd say 20 to 28 or so, the age range of people that have their first break. And what first break means is when they become psychotic for the first time, delusional, etc. About the same in men and women. The onset is earlier in men, and you see the other statistics there. About 3 to 10% of women have the disease onset after 40. So again, they still fall in that kind of 20 to 30 range. But some people with schizophrenia have their onset after age 40. Men are more likely to be plagued by negative symptoms, which are anhedonia that we talked about, and so we'll get into the negative symptoms a little bit more later. There's some research around birth season. People born in the winter, early spring, there's more common diagnoses of schizophrenia. It's really not known the exact mechanism by which it's transmitted. People may have an exposure to the flu in the second trimester of pregnancy. Substance abuse in schizophrenia is very high. If you've ever been out to Eastern State Hospital here in Lexington, you will see many people standing outside smoking, and smoking is huge. Well over 50% of people who smoke or people who have schizophrenia smoke. And so, of course, this increases the risk of hospitalization, and it may increase other psychotic symptoms as well. And about 90% of them are nicotine dependent. So, again, there are some other theories around there. It's really fascinating. There's a guy here at the University of Kentucky who does some research in this area. And it may be a form of self-medication. It may calm them down, maybe calm the psychotic symptoms down a little bit. You see the prevalence of genetics in this. So if you have a monozygotic twin of a schizophrenic patient, you will have, there's about a 0.5%, about a 50% chance that their twin will also have schizophrenia. There's some research around dopamine. I'll let you do some reading of that on your own. There's some research around neuropathology, the cerebral ventricles. Again, not super important unless you're just interested in kind of the etiology of schizophrenia. There are some historical family dynamic theories, though, that I want you to know about. That used to be, and Sigmund Freud was in on this. The people in earlier years thought that schizophrenia was caused by what they called icebox mother. So this was a mother who was cold and rejecting of the person. So if you read some of Freud's earlier work, you will see that he talked about that. There is really no evidence at all for any causal role in the development of schizophrenia in terms of the mother. So that theory has been debunked. Some researchers have looked at expressed emotion, so the negative attitude that family members might have toward their mentally ill relative really looks at, and so think about it. If you have someone in your family who has schizophrenia, they won't go outside, they won't get out of bed, they are afraid, they maybe won't take medicine. This is a pretty robust predictor of relapse for them. So in expressed emotion, you're looking at families that are critical, hostile, or kind of emotionally over-involved, which can be a problem. So when you're working with people who have schizophrenia, we want to make sure that they have a safe and stable home to go home to, a supportive family, and so that they don't relapse. There are lots of interventions, thankfully now, pharmacological interventions for people with schizophrenia. The first generation drugs were things like Thorazine, Prolixin, Navaine, Haldol. These all had pretty bad extrapyramidal side effects in about 60% of the patients. So let's talk about EPS. This can occur within the first few days of administering the drugs, or even after months or years. So we're looking at things like tardive dyskinesia, and I'll try to demonstrate that to you now. So if you're talking with someone who usually is a long-term patient with schizophrenia, and they're doing something like this, like that, that is tardive dyskinesia. So they're licking their lips, they're kind of sticking their tongue out like that, they're rolling their tongue. That is a medicine problem, and that needs to be addressed with a physician. They can reduce their dosage or change the medicine. Some Parkinsonian kinds of symptoms come about too, where person can have tremors, have lots of rigidity in their arms and their legs. People also experience akathisia, so this is by this kind of restlessness, this internal restlessness that they have, so lots of pacing and inability to sit still. And acute dystonia is really bad. That's where they have the spastic contraction of their muscle groups, like in their neck or their eyes. So if you can imagine how painful, if right now, if this muscle in my neck just kind of contracted violently, how painful that would be for me. And they can be very sudden and very painful. A very dangerous syndrome is neuroleptic malignant syndrome, and this is potentially fatal. It can include problems with blood pressure, cognitive dysfunction, and tremors. Benadryl, Cogentin, these things are commonly used to treat that. There are thankfully some newer antipsychotics, Geodon, Seroquel, Zyprexa, Abilify. These are good medications. They do have some side effects, weight gain, high blood pressure. So again, working with a physician to help prescribe the right medication for someone with schizophrenia is really important. There are some assertive community treatments. This is common now. So again, it supports the person outside of the hospital. It does housing. It helps with job training and that sort of thing. It's available 24/7. Somebody is on call. And so they're doing case management, they're doing assessments, they're doing employment and housing, family support. It's kind of the whole package. To me, it feels very kind of social worky. It is evidence-based, and it's also cost-effective. So in schizophrenia and recovery, we're looking at emphasis being placed on growth of the individual. This is not a death sentence. We don't have to house these folks in a hospital for years and years. And so the patient plays a really hands-on role in getting well. So if you go out to Eastern State Hospital today, you will certainly see hospital beds that have locked doors on them. That sometimes people need to be restrained, it's pretty uncommon anymore. But what you're more likely to see is what they call the recovery mall, where the patients are talking about finances, and they're talking about school, and they're talking about how to cook food and how to grocery shop. It's very hands-on, and so this is a great new way, I think, of thinking about patients with schizophrenia. It teaches them how to access resources, and it's kind of a psychosocial clubhouse, which is a really, really good model.